So good evening or good afternoon or good morning, depending on the part of the globe that you're watching this exciting webinar that we've prepared for you today, where we'll listen to three fantastic authors on papers and research on how to use the biceps in rotator cuff tears. We'll start off this webinar with Professor Sae Hoon Kim from South Korea, where it's very early in the morning, to talk to us about the biceps rerouting during rotator cuff repair. And then we'll hear from David Endell, talking about his research with Marcus Scheibel on the biceps smash slice technique, the biceps tendon autograft augmentation also for rotator cuff repairs. And finally, last but not the least, Alexandre Lädermann will talk about their research on the use of the long head of the biceps as an autograft augmentation for subscapularis repair. So as promised, Professor Sae Hoon Kim, you have the floor. Please present your research to us.
Thank you. Good morning. I'm Sae Hoon Kim from Seoul National University College of Medicine from Korea, also Secretary General of KSES. Thank Dr. Azevedo for organizing such a brilliant program. I'm honored to be here, a member of this fabulous session. Today, my short talk is biceps splinting during a rotator cuff repair to minimize the risk of retears. We all suffer to meet a common complication after rotator cuff repair, which is retear. Study shows that about 26.6% of rotator cuff repair result in retears. While some patients still experience tolerable function after a retear, it is generally accepted that better outcomes are achieved with intact repairs. Therefore, avoiding a post-operative retear is critical. Retears are influenced by several factors, patient-related factors such as age, comorbidities, metabolism, and muscle degeneration, intraoperative factors like the repair technique and mechanical protection. Other factors, including surgeon skill and rehabilitation quality. The goal is to find a way to protect and support the LCR intraoperatively. When choosing protective measures, we ideally want readily available local tissue, minimal invasiveness and risk of infection, low cost, and minimal operative time. So long head of the biceps met this criteria and are ready to use. The techniques of using the biceps have evolved over the years. There are several techniques available when utilizing the biceps in rotator cuff repairs. Proximal tenotomy for biceps augmentation, distal tenotomy for biceps superior capsular reconstruction, maintaining continuity for biceps rerouting, reshaping the biceps for patch grafting. These techniques are effective for addressing various complications during rotator cuff repair. In broad sense, all procedures involving the biceps to strengthen the repair can be referred to as biceps augmentation. However, in the literature, biceps augmentation specifically refers to biceps interposition following proximal tenotomy. Most importantly, biceps does not span to the glenohumeral joint. Biceps SCL spans the biceps along the glenohumeral joint, preserving its proximal origin with the additional humeral fixation, and also includes concept of biceps rerouting. However, in a narrower sense, biceps SCL involves distal tenotomy, while biceps rerouting preserves continuity of biceps throughout. Biceps augmentation aims to reduce repair tension in massive tears by interposing the biceps tendon. However, this technique is now largely obsolete due to concern over proper tendon integration and obstructing the cuff healing. Biceps superior capsular reconstruction involves distal tenotomy and possibly tenodesis, keeping the proximal origin intact. The biceps stump is attached to the humerus and multiple strands are used for fixation. The outcomes of these techniques are comparable to traditional SCL technique. Now allow me to present biceps rerouting. This technique reroutes the biceps through to provide better support to the humeral head during rotator cuff repair. It involves removing the biceps groove and creating a new path, neo groove, for the biceps. While it adds operative time, the technique offers optimal protection when the bicep tendon is healthy. Biceps-related pathologies are common when there is a cuff tear. It has been reported as high as 82%. Classically, rotator cuff repair with tenotomy or tenodesis had been standard procedure to these pathologies. Our concept of biceps splinting is to create a simple temporary splint to protect the cuff during initial healing. It's not expected to last forever, so for such purpose, a pathologic biceps may be used. However, there are concern of ripping a possible pain source. A retrospective historical cohort study was undertaken with the patient who received the cuff repair with a concomitant biceps lesion or a type 2 slab. In our institute, the biceps procedure has been completely to shift from subpack tenodesis to splinting in 2018. After exclusion, 32 patients in each group with 1 year MRI and minimum 2-year follow-up were analyzed. Our mainstay of repairing cuff is a single load repair with triple loaded anchors. On only subpack tenodesis was done using an all suture anchor. In biceps splinting group, after releasing posterior pulley, a single wraparound suture around the biceps forming a L-shaped route, other strand incorporated into cuff repair. It has less than 2 minutes in OR time. Here is an illustration of biceps splinting. A partial bicep tear is seen and an anchor is inserted at the articular margin according to tear configuration. That is a tear shape is L-shape fixation. L-shape fixation point is rather anterior or reverse L-shape. It is little posterior to reinforce the repair. A simple single wraparound suture was placed and tied, and the repair is completed over the biceps. 1 year MRI shows well-healed cuff. A ruptured biceps origin is noted, but the biceps is adheres to the biceps groove with no Popeye deformity. Here is a simple video shows medium-sized tear, delaminated tear. There's a little bit of posterior pulley lesion, but biceps seems okay. So I put the anchor at the articular margin, and there goes a simple wraparound suture and tie down to the articular at the anchor site. That's all. And the final repair looks like this. There were no significant difference in baseline data in each group, including functional scores and tear size. Biceps-related pathologies were also similar. All outcome score differences were not significant, including no occurrence of Popeye deformity in both groups. In postoperative MRI evaluation, there was a significant difference in retear rate, 30.4% in subpec tenodesis group and 12.5% in biceps splinting group. In subgroup analysis, protective effect of biceps is more evident in medium-sized tear. In biceps splinting group, biceps was preserved in 24 cases. In this situation, retear was not occurred. However, in biceps torn cases, half of them showed a retear of the cuff repair, which means biceps could work as protector of a rotator cuff repair in early post-operative period as a splint. Here's another case illustrating protective effect. A large-sized tear was repaired with splinting. Immediate post-op MRI showed good tendon coverage. The patient was extremely non-compliant and removed the shoulder brace upon discharge, used the shoulder as usual. Here we can see while splinted biceps has been torn, the repair was intact. There are options for bicep procedure when we met bicep pathology during rotator cuff repair. Just remove pain source or augment the repair. Bicep splinting with even with the pathologic biceps definitely lowers retear rate, and it's extremely simple procedure. So why not doing it? Thank you for your kind attention. And I will turn my microphone to Clara. Thank you.
Thanks so much. This is a concept that I think is amazing. We're moving from being biceps killers to biceps users, and showing that even if it's pathologic, we can still use it and have excellent outcomes. Thanks so much, Professor Sae Hoon Kim. So now we'll move on to the next paper and presentation. David Endell will join us to talk about the biceps slice smash technique.
Thanks for the introduction. Unfortunately, I can't start my video. Maybe I can get some technical help. I hope the slides are available for everybody. I'm honored to talk about the bicep smash and slice techniques. These are strategies to augment the rotator cuff reconstruction utilizing autologous biceps tendon tissue. So there's different approaches and different augmentation strategies in rotator cuff repair. And we're very excited about the biceps tissue since that's an autologous tissue. And there's several other advantages, some of which we've heard already, but I want to repeat them very quickly. So the long head of the biceps is a tendon tissue, which is very easily accessible. And we can utilize it and we can take it right there. It's for free. It's autologous, which has several advantages. And it's biomechanically stronger than other tissues we've been using before. For us, that's been the bursa. And we see that it's rich in tendinous stem cells. And there's two basic strategies as we can utilize this tendon tissue. So one is augmentation, we're going to talk about in a little bit. And this means augmentation of the classic rotator cuff repair. And the other one is utilizing as a sort of superior stabilizer in those situations when the rotator cuff is irreparable, sort of like an SCR, or there's an anterior capsule reconstruction, or to reroute it. So there's been now some systematic reviews coming out investigating biceps patches as augmentation techniques. This study summarizes 6 studies from more recent, but also a study from 1971 with mixed approaches. Open and arthroscopic techniques have been described. And here the patients benefited greatly concerning pain mostly, but also for flexion and elevation and the patient-related outcome measures. What one has to keep in mind, these techniques all have in common their interpositions. So they're not true augmentations. These are all irreparable situations where a gap remains, which has been closed, utilizing the biceps tendon in different mechanisms. So to mind again, these techniques that we're looking at are utilized as an augmentation for rotator cuff repairs where reconstruction is available. And the background behind this is that in the last years of the millennial and the early 2000s, mechanically, the rotator cuff reconstruction has been optimized by introduction of new suture techniques and new anchors, new generation of anchors. But something that's been then observed is the medial row failure, the type 2 failure. This was a previously unreported mechanism of failure, and it's been happening since double row rotator cuff repair has been introduced. In this study, Joe et al. Was nicely described, compared single row and the double row reconstruction here, labeled as a suture bridge. So the single row showed a more lateral retear pattern, the type 2, about 74%. And now vice versa, the double row technique showed actually more medial retear pattern, which is interesting. And something else we need to keep in mind, this interesting study by McCarran et al., they investigated what happens immediately after the rotator cuff reconstruction, and they used tantalum radio-opaque markers and placed it within the tendon, and then observed it within 6, 12, 26, and 52 weeks with a CT scan and an MRI scan afterwards. And they were able to document that for all repairs, for all tendons that have been reconstruction, there was a retraction to be observed of some sort in all tendons. So this is interesting. So we can't be too naive about what happens to our reconstruction. So there is a need to augment biologically our rotator cuff reconstructions, and something that's been emerging, these off-the-shelf bioinductive collagen implants. For example, the Regeneten, and this is a very recent study, level 1 RCT. It's an interesting study because they compared the traditional transosseous repair with transosseous repair and a bursoside bioinductive collagen implant augmentation. And they performed MRIs at 1 year, and they were able that this augmentation is able to show reduced retear rate of 8.3 versus 25.8%. But not only that, they were able to see a bit of a shift in the Sugaya grade. So the bioinductive collagen implant showed more of the type 2 Sugaya, and the insufficient thickness and the actual retears happened a lot more in the control group. Another observation that the authors were able to make is that there's an increasing thickness of the tendon. So they categorize these in 3 areas. So at the footprint to the medial row, and then 10 millimeters medially from the medial row, and another 10 millimeters more medial. And they were able to identify statistically significant thicker tendons in these cases where the reconstruction of the rotator cuff was augmented. And lastly, another very interesting observation that they made, that in these 21 cases that they had a retear, there was a type 1 failure found in 4 cases, which was evenly distributed between the groups. But more commonly was a type 2 retear in 17 cases. And most of these happened in the control group, and very seldomly in the augmented group. So there is now a new trend that we are able to observe, that these type 2 medial failures become maybe less common if we perform augmentation. But these now off the shelf and not autologous tissues. And this is where our techniques can come into place, because the biceps is an autologous tissue which we can take. It's right there. We talked about this previously. I want to briefly talk about the indications again. So we can use this arthroscopically as a bursoside augmentation of the medial row for our standard posterior superior rotator cuff reconstructions, but we can also utilize this in open surgery. For example, when we reconstruct the subscapularis after tenotomy in shoulder arthroplasty. Here we see how the biceps tendon is harvested subpectorally. We get a good length, about 6 to 7 centimeters, even longer in some individuals. And then even if we see a partial tear of the tendon, more proximally, we're able to harvest a good portion of intact tendon, and then afterwards repressing it for 3 minutes. And these presses now also come in larger shapes, so we're able to get a good size of the patch for a later augmentation. So it doesn't really matter how you want to perform the subpectoral biceps tenodesis. But what Florian Fleischeder from our clinic was able to show that if you perform the in situ tenodesis, you might get a bit better cosmetic result, no matter how you do the tenodesis. So pectorally, you will always get a good length. So here we see the press biceps patch. Now it's extracorporally shuttled with the medial sutures of the medial row. They've been already previously knotted inside. And now in sort of a flying carpet technique, the patch is applied in the suprachromal space using 2 knot pushes. And it's then tied on top of the medial row. Again, the medial row has already been knotted, and now the sutures are knotted once more to fixate the graft. Bursa sighted on top of it, and we can see a good primary stability, but it's still able to flip over. So that's why we performed another suture on top to prevent that the patch is flipping over or causing impingement. And afterwards, the sutures are secured laterally in a double row classic standard fixation. And here we see the final results, the posterior superior reconstruction of the rotator cuff, and on top the biceps autograft patch. So another approach for how to prepare the biceps patch can be that you don't press this, but that you slice it. The rationale behind it has been that by slicing it, you're utilizing instruments which you have at any surgical table available. It's an easy technique which you can do in seconds. And we're thinking that this technique, by slicing it longitudinally, will possibly preserve also more tenocytes. And this video that we now see has been done by Amadeo Tue. And here we see the biceps has been longitudinally sliced open in a sort of open book technique. The first incision is done while the assistant holds the tendon. Now the second incision is done, but the hinge is left. So it's not cut into 2 pieces. So it's left as one piece, as an open book, which is afterwards attached to the subscapularis reconstruction here in a total shoulder. Arthroplasty first fixated proximally and distally, and then median and laterally. And here we see we can achieve a good primary fixation with it. So some studies have come out that investigated what happens biomechanically to these patches. So this is a bit of a different technique. Keep that in mind. This is a mesh technique. Here we see the graft has a few holes in it. It's not pressed, it's not sliced, but it's meshed. And if we look at the graft, we're not surprised that the authors were able to identify altered tensile properties with a reduced tensile strength, and also observed reduced tendon viability. Another study that's now investigated the pressed biceps tendon. This has also been published very recently. And they compared the pressed biceps tendon and the native tendon, and they were able to observe that pressing the biceps tendon does not mechanically damage the tenocyte morphology. The vast majority, or over 3/4 of the cases, showed normal tenocyte morphology in both groups. And necrosis usually happened in both groups, the pressed and native tendon, which indicates that there might have been an issue with the tendon even before pressing it. And this is also in line with our first investigations we have done. Here we see histopathological slides of a pressed tendon on the right side and the native on the left. We see a more ruffled collagen and more ruffled structure, but overall the tenocytes are left intact. So there are several advantages of the biceps tendon autograft patch augmentation, and the primarily advantage is obviously that it's autologous tendon tissue from the patient, him or herself. And we have no additional donor site morbidity, since in most cases we're performing a biceps tenotomy or tendesis anyway. And we can use our standard rotator cuff reconstruction techniques, and we don't need to alter that. And we're not expecting any foreign tissue reactions because we're using autologous tissue. And it's a lot cheaper than off-the-shelf patches, and it's actually for free. It's right there. We just need to take it. A drawback can be initially maybe an additional operative time, especially for those arthroscopic reconstructions, and the learning curve needs to be considered. And mostly we need biomechanical and cellular evaluation of what happens with these patches, how they ingrow, and how we need to place them. And afterwards, obviously, we need prospective clinical studies to investigate this. Thank you very much. And we would like to invite you to come to Berlin next year.
Thanks so much, David. And next is Alexandre Lädermann, who's going to talk about another use of the long-headed biceps to augment the subscapularis tendon tears.
So here I am. Good evening, everybody. So this will be quite clearly a more technical part than what you see previously. If I can have my video, it will be great. Don't hide me, please. So I'm Alexandre Lädermann from Geneva, and I will show you how I use the biceps, but still pediculated. Okay. It should be fine. This is my conflict of interest. This is things that we already published. So if you want to look at the video, this is already available on the platform BMed. There is the article, the video, so you can refer this if you want to read, to see again this video. This is the roadmap of the presentation. When do you need a graft? What are the requirement properties of this graft? Why do I use the biceps? And if I use the biceps, how do I do this with the scope and in open surgery? So when do I need a graft? It can be the subscapular, but also the supraspinatus. When I have a doubt about the quality of the tendon, honestly, I don't have 26% of retear, so I don't need a graft in every single case, but I think that in some situation, this could be really useful. And then it's when I have the repair that is under tension, and also what I need is a biceps for this technique in continuity. So what are the required properties? And I think that this is, for me, crucial. When you think about a graft, ideally, it has to be local, it has to be an autograft, it has to remain pediculated and vascularized. I don't want to feel the retrocoracoid or the subacomal space, so this is something that has to be low profile. And this is why I think that it has a very nice place in the rotator interval. This is something that needs really to be strong, not a papyrus, but I keep the biceps intact to have really a strong construct. And this is something that has to be inexpensive without additional device that, of course, you need to pay to the company to prepare the graft. So this is everything that I need. And if you think about it, for me, the best graft is, until proven otherwise, the biceps. So why the biceps? Because in most of the case, and this has been proved for the subscap, in 90% of subscapularis lesion, your biceps is either unstable or pathologic. So why shall I keep it? So how do I do? This is a nice technique that has been published by Tiago Martino. We simply keep the biceps in the bicipital groove and then fix it firmly to the upper part of the subscapularis. And as you can see, this remains in the rotator interval to have really a low profile repair. So I don't want to, you know exactly how we repair a subscap. This was a very retracted subscapularis, so I use a traction suture. I did a release of the subscap, 270 degrees release. I prepare the subacomal space and so on to make sure that I don't have too much adhesion. This subscapularis was really retracted, and this is why I decided to do a release. In most of the case, I don't do this, and this is also why I decided in this case to use the long head of the biceps as a reinforcement. Then you put your screws, in this case, 2 screws. I just push the suture in the posteriorly to the subscapularis, and I pass them progressively with a suture passer, doing for the upper part a lasso loop. And so when it's done, the subscap is repaired, and this is now that the work with the long head of the biceps will start. So the first rule is the biceps has to be fixed in the upper part of the bicipital groove. So you need to do a tenodesis of the biceps. Otherwise, it could actually create a damage to the remaining subscapularis if these remain unstable. So it has to be well fixed in the upper part of the bicipital groove. And then I use a suture passer, and I will do 2 lasso loop around the biceps at 2 different levels. One close to the bicipital groove, and the second one close to the glenoid, to its origin. So I pass my suture through my lasso. I do it twice, so the biceps will be really surrounded by the suture. And when it's done, I will pass this suture through the subscapularis. So I push one of the 2 sutures posterior to the subscap, and I will then fix it to the upper subscap. And when this is done, you just repeat the same maneuver for the proximal part of the biceps. So again, you pass your sutures, you do your lasso, you fix it to the upper subscap, and then you simply have to cut the long head of the biceps. And the biceps, when you will tighten your suture, will just go in the rotator interval just above the subscapularis. And this is a very nice and strong reinforcement. And as I said, this is pediculated. And if you want, you can add, like in this case, other suture to have even a better compression of the biceps. So this is the final result from the posterior view, but I will also show you the final result from the superior view. And you see that this is very low profile, so there is really nothing in front of the subscapularis. What about the open technique? So it's interesting, you can use the long head of the biceps for the subscap. This is in case of prosthesis, for instance, but you can also reinforce the supraspinatus. So just depending of the direction of your biceps. So this is another video. I'm going to be quite fast because, so the first rule is to do a tenodesis of the biceps in the lower part of the bicipital groove, and then do not open the bicipital groove, because this will weaken the subscapularis attachment. You just fix the long head of the biceps in the upper part of the groove, and you keep these biceps like this. And at the end of the surgery, so I prepare, I pass loop suture through the through my bone, then through the subscapularis. I do side to side. I keep this loop suture, and then I will do two nuts. It's Corwich nuts, and I will take one suture from the upper limb, one suture from the lower limb, and then I will obtain, tightening progressively this suture, transserous double row repair. This is a nice technique that we published with Patrick Donard in 2018. And at the end, I will use these biceps, and I pass multiple suture from the biceps to the subscap. So the biceps is still attached, pediculated. I'm aware that passing suture through a tendon compromise the vascularization. However, there is still vascularization, and you can do this for the subscapularis, but also for the supraspinatus, like in this case. So very strong construct, and I think interesting reinforcement that is low profile because it stays in the bicipital groove. What about the rehab? I have the tendency to protect my subscapularis because you have an important lengthening if you move your subscap right away after the surgery, 117%. So this is why for the moment I keep them in internal rotation, but I think that I need to reevaluate this because the constructs are so now powerful that I'm just wondering if I could let my patient move right after the surgery. So thank you very much for your attention. And I hope that we will have nice discussion and nice questions.
Thank you so much for all your presentations. I think we have a lot of discussion to do here. First of all, I would like to say that one of the things that most impressed me about the research from South Korea, Professor Sae Hoon Kim, was that you apparently answered a question that we all have or had, which is if we should use the biceps when it's torn, partially torn, if you have a slap to tear, so you have pathology, and your paper shows us that it doesn't change the outcome. So we can still use your technique even if there's a pathological biceps, right, Professor?
Yes, I think so. I mean, at first I used the biceps, splinting. I was skeptical of using biceps when biceps is healthy, because in that way you have to release yeah, there's the excellent paper by Washu group that rotator cuff starts from 5 millimeter posterior to biceps group. So when the biceps is healthy, usually the anterior cable, or what can I say, the posterior pulley is intact. So in that case, I don't use biceps at all, because the biceps healthy, and you have to release some of the supraspinatus anterior fibers. So I use this technique for only the patient with the bicep pathologies. So my research shows that even the biceps is pathologic, like a partial tear or posterior pulley lesion or a type 2 slap lesion, it could reduce the retear rate, and it's very simple procedure. So why not doing it?
Yes, but now you placed a doubt in my mind, which is, so if you have a full thickness rotator cuff tear and the biceps is completely healthy, you don't use the biceps splinting technique to reduce the retear rate?
No, with seeing my research, I a little bit shifted my concept of bicep splinting. So if you are not releasing, the supraspinatus footprint, if there's some fiber at the posterior pulley, I release it, and I do the splinting technique. So if not, if there's not much the tissues from the supraspinatus at the anterior side of the footprint, I do the splinting technique and for now.
Okay. David, there's a question for you in the Q&A, but I'd like to ask you a question first. You showed us the different way of using the biceps, either the smash or the slice. I have a question for you regarding the concept of this idea. I understood that when you do the slice technique, it's much easier and simpler. You can use typical instruments that you have in the OR compared with the smash technique. But one of the reasons you were using the smash technique was that you placed it transverse to reproduce the orientation of the fibers of the rotator cable, right? So now if you place it longitudinally in the slice technique, you're not doing that. You're actually doing something similar to the rerouting. Why the two differences for you?
Okay, that's a very good question. But what we have seen with the slice there, we've been mainly using it in their arthroplasties, and the reason why we've been doing that is because it's also much more easy. We don't need to open another set of instruments. We can perform it right there. It takes seconds. And there with the slice technique, we are still perpendicular to the fibers of the subscapularis. For the arthroscopic techniques, we've been mainly using the press technique. But there's a lot of still open questions. We still don't know what is the best way to place it. So do we open the book and then we place the open book facing the reconstructed tendon, or is it better the other way around? Or does it the slicing Does it alter the morphology and the primary strength of the biceps too much? These are still open questions we need to investigate in vitro.
Okay, so regarding a little bit of that, Kick asks if so there is little necrosis from the biceps grafts. Does it get some vascularization from the surrounding tissue?
So this is something that's entirely different in our strategy. We're using a free patch, so this is not pediculated and this is non-vascularized. So will it get some later on ingrowth vascularization? The answer is we don't know. We have only in vitro data, which is showing there is little necrosis, which doesn't mean little necrosis for each tendon, but then in a few cases we see an altered morphology. So I think what we can derive from that is that for most tendons, it doesn't matter if you take a native or if you press it, and we'll not see a lot of necrosis. But to be honest, what we probably will see is more of a fibrous hull that will emerge, and afterwards a sort of creeping substitution with the recellularization process, as we probably know it from the ACL replacements. So I think the collagen inside this patch is what will be an add-on for the healing.
Thank you. Alex, your technique is pediculated. So it seems to be advantageous in this respect. You also placed here saying that you would answer a question live, but I can see the question from Amr Kandil.
No, yes, I try to. No, I'm not doing anything. I'm sorry.
Okay.
I was just saying, I wanted to say hello to Dr. Kendall, but
Oh,
I
sorry.
failed.
Okay,
I failed badly.
Anyway, there's another question from Augustinus Rimkunas, who would like to ask, if I reroute the biceps to the anterior medial anchor for rotator cuff repair, do I need to release the biceps tendon sheath or perform additional biceps tenodesis in the sulcus? Would you like to answer this, Professor?
Yes, a good question. The biceps for the biceps rerouting, which was introduced by Yang Soo Kim in Korea, he put two anchors. For me, there's using many anchors for only fixation. The fixation for the biceps is kind of waste, so I use only one anchor and one wraparound sutures, so it makes a little bit of killer turn, like L shape. So if you don't like that, you release all the biceps all the way to the transverse humeral ligament, and you place two anchors, then it makes a little bit, looks good. But however, I don't think that kind of cumbersome procedure is not needed. So I usually release the posterior pulley part, not all the way down to the biceps groove or transverse humeral ligaments. Just doing that, you can pull the bicep to the articular margin with a little bit of the L-shaped killer turn. So I don't think you don't need to release all the way down to the groove.
Okay, David, this question is from me. To perform your technique, you need to do a subpec tenodesis because you need a significant length of long-headed biceps to perform it, right?
So this is my standard technique, which I do for my biceps tenodesis. We've seen you don't need to do it necessarily, so you can also do the more proximal articular one. But then you might find a tendon which shows some abrasion or a partial tear. So in our experience, if you do the subpectoral one, you will always find a good portion.
Okay. There's another question here about the rehabilitation. If you change the rehabilitation for all of you in terms of external rotation limitation in these patients.
Maybe I'll go first because my answer is the easiest. We do not alter it at all because we're performing a standard rotator cuff reconstruction, and we're augmenting what we're doing. So they receive our standard rehabilitation.
Alex?
So for the subscapularis, we did a prospective study with Patrick Donard published in December 2016. And in this study, we compared the subscap repair after prosthesis. And there was two groups. One group had immediate postoperative range of motion, and the other group was immobilized in internal rotation during 1 month. And what we observed is that it was, even if it was not statistically significant, there was a clear trend for more subscap insufficiency at 1 year if the patient were moving right away after the surgery. And this is probably why, as I explained, the subscap, as soon as you move it, the elongation is quite important, 117%, and it could create a lesion again of your tendon. And this is why we developed this technique with Patrick of transverse double row reconstruction with the 2 co-hinge nuts and the suture loops. And now we are adding the long hair of the biceps. So clearly our repair is better than what we were doing in 2016. And I am now thinking again about either redoing a study or at least letting my patient move a little bit more postoperatively. So yes, it has changed my practice.
Professor Kim?
Yep.
Do you change something in the rehabilitation in terms of external rotation limitation for your patients?
Not really, actually. My my rehabilitation program for rotator cuff repair is a rather standard. It says whether what I do, if I don't do the muscle advancement, I immobilize shoulder like 5 weeks total, and it doesn't matter whether I do the biceps splinting or not. Okay.
Okay, there's a very nice question here from Endell, which is a drama that we may face now when we have irreparable rotator cuff tears of the supra and infra with concomitant irreparable tear of the subscapularis. The question is how you prioritize the use of the long head of the biceps. So the long head of the biceps is only one. We have to choose either the subscap augmentation or the supraspinatus augmentation. Who wants to answer first?
So for me, my subscap results are probably better than the superior cuff, and I will prioritize the repair of the superior cuff, knowing that my return rate after subscap lesion is not so high, except if I have very severe retraction.
So you'd use long head of biceps to augment posterior superior rotator cuff tear, and
yes, I do.
Subscap?
I do biceps SCR if I have a posterior superior cuff lesion.
Okay. David?
Probably for me the same. So the question to me is the cuff reparable or is it irreparable? And if we can't repair it, then I would probably also do sort of like an anterior biceps SCR. And then for the technique that we've been describing, so there we have a reparable situation. And I also have a bit more confidence in the healing of the subscapularis than in those, especially the degenerative posterior superior tears. So in these cases, I would favor the posterior superior cuff.
Professor Kim?
Yeah, I'll go with Dr. Lädermann. I'll reinforce it with the bicep to the subscap. And one thing different is for the first posterior superior tear, I I do the muscle advancement if it's irreparable or it has a lot of tension to reduce. That's the
Okay.
difference. Okay.
We have a question from Portugal, from Pedro Marques. What about dynamic biceps rerouting with a new bicipital groove more laterally? Do you see any use in this technique? I think this is a good question for you.
It's very novel idea, but if my understanding is correct, this doctor means that you make just a groove and don't fix the biceps to the groove, the neo groove. In that way, there's no fixation to the biceps, which means it's unstable. Even if you make a trough deep or whatsoever, when it rotates, it easily dislocate to the anterior. I think it makes the repair construct dangerous. And in other sense, the biceps is still moving at biceps neo groove whatsoever at the humerus. In that way, you have a partial tear or biceps pathology that will make a pain source, I think. So my guess. When you fix the biceps at the groove or whatsoever, we expect some kind of the tenodesis, tenodesis effect at the biceps groove. In that way, whatever the biceps has pathology, I don't see any bicipital tenderness or bicipital pain after the splinting or suprapectoral tenodesis. So the idea is very fancy, but I don't think it will work. So I haven't seen anybody doing it. Okay, nice idea.
Thank you. Another question for you. You're being bombarded from Dr. Hesh. Go wish. Does the biceps really heal to the cuff, or does it not heal?
Wow, it's very nice question. I think that as I said before, I think if the biceps is not movable at the biceptal groove at the humerus, I think the distal part it heals. It adheres to the biceps, the local tissue like biceps groove, vinculum or whatsoever. But I'm not sure it will heal to the supraspinatus. I needed some kind of the second look arthroscopy or some whatsoever. But in MRI, even the biceps is intact. You can see the biceps structure after like 1 year MRI or afterwards. So I'm not sure. So it's just a splinting, or as time goes by, it sticks to the supraspinatus. I cannot answer for now. I will study on that. Thank you.
Yeah. So my interpretation from your study is that actually doesn't matter, because as you call it splinting, you explain it so well. Is the idea is to protect the repair you did on the rotator cuff while it's healing the rotator cuff itself. So the long head of the biceps is there protecting this repair biomechanically. That's why even if it fails later on, then the cuff is already healed and there's no issue. That's what you showed. So it doesn't matter if it heals to the supra or not. We have more questions here for Dr. David from Amr Kandil. How do you overcome the concerns on compromised thickness, weakness of the splitted, spliced long head of the biceps graft? David.
Okay, so I think we're talking about the slice technique. We're not talking about the splitted or partial tears that we see sometimes that happen to the biceps degeneratively. We're really not very concerned about that. It takes a bit of practice, I would say, to leave a good hinge. But when you think about it, you're cutting longitudinally the biceps in half. So what you get is two pretty much even halves of the biceps, which we have not further compromised. So there we have a pretty good thickness. So I think the crucial part is that you don't leave a hinge that's too small, because that's going to be the weakest part of the patch.
Okay, there's no more questions. Do you want to ask questions to each other?
Yeah, sure. I have a question for Professor Kim. So I think that the concept is very interesting of using the biceps as a splint. And I want to, of course, congratulate you to your concept and your work there. But as a splint, it has to come off eventually, so the patient can move again. Are you doing anything to the biceps sort of to provoke that an autotenotomy is happening, that it ruptures? Or how do you ensure that this is actually happening? Because I have a bit of the concern that the patient might experience still some pain if it does not tear.
Yeah, that's a good question. For like a biceps, what I confirmed about this technique is after the the SCL comes out. So the capsule is rather thick than we always thought. So we are just creating, the biceps origin is still there, and we are just making fixation point at the articular margin. So is the path or the attachment point is similar to capsule. So I think the capsule is gone when there is a rotator cuff tear. So just creating that kind of structure by the biceps can work as a the protective effect of the rotator cuff repair. That was my thought, and I was yeah, like you said, I was a little worried about the range of motion and everything after the protection effect is gone. But some patient I showed in the result, some patient suffers with the biceps the rupture. But in that case also some of them had the perfect rotator cuff healing, and there is no kind of any the functional score differences. So I think I'm not sure. I cannot explain 100% to persuade you to do the procedure. However, I think it works. Like a concept of then there is no way the SCL works or other kind of the non-dynamic construct works. So I think it's already there and very simple procedure. So why not doing it if it's there? So yeah, unlike your fancy procedure, but it's very simple. So yeah, I think it easily done by the novice doctors or whatsoever. Thank you.
Thank you so much. We'll have to
Mhm.
end this amazing SECEC webinar. I thank you, Professor Kim, for participating at this very early hour in South Korea. David
Yes.
Endell, Alexandre Lädermann, thank you so much for sharing your research and your wisdom. So see you next time.
Thank you all. Good evening.
Thank you very much. Have a good evening.
Yeah, have a wonderful rest of the day. Okay. Thank you, Clara.
So much again. Bye.
Bye.
Bye-bye.